Hi guys, I'm Riley, and today I'm going to be presenting some research on stress and neuropsychiatric symptoms in systemic lupus erythematosus patients. Systemic lupus erythematosus is, well, first of all, also called SLE or simply lupus. It is an autoimmune disorder in which the immune system attacks the healthy tissue and organs in the body, resulting in infection and chronic inflammation. Lupus is a genetic disease. It's caused by genes, but it is largely influenced by the environment. Environmental factors like stress can trigger not only the onset, but the progression of the disease as well. There are three main risk factors associated with lupus. They are sex, age, and race. Females are at a much higher risk than males for developing lupus. And although it does affect people of all ages, lupus is most often diagnosed between 15 and 45 years old. And it is much more common in Hispanics, Asian Americans, and African Americans than any other race. So, like we said, lupus causes chronic inflammation in the body due to the immune system attacking itself. But what does that look like? There are both symptoms and complications associated with lupus. The symptoms are the direct result of the inflammation in the body. The most common ones are fever, skin rash, joint and muscle pain, swelling, fatigue, breathing problems, headaches, depression, anxiety disorders, cognitive dysfunction, and psychosis. And then we have complications. Complications are the health issues that are usually a result of unmanaged symptoms. So these are much more severe, and they are not directly caused by lupus, but a result of lupus-like symptoms. So the most common complications are organ damage, blood problems, damage to the central nervous system, which then causes cognitive and behavioral changes, increased risk of cancer, cardiovascular disease and heart attacks, infections, strokes, and avascular necrosis, or death of bone tissue. So most of the symptoms and complications we just talked about were physical. But it is also important to note that there are a lot of psychological symptoms and mental disorders associated with lupus. In fact, 20 to 70% of SLE patients experience neuropsychiatric symptoms, 11 to 39% of these being depression, with 9.5% of those at risk for suicide. Other psychiatric symptoms associated with lupus are mania, ADHD, anxiety disorders, psychosis, and other cognitive dysfunctions like memory loss. There is also a process called illness uncertainty that is largely influential of lupus in patients. So illness uncertainty, when we look at lupus, we're looking at a very unpredictable disease that is difficult to diagnose because it presents like so many other illnesses, and it's difficult to manage and track. This uncertainty of what is going to happen with the disease can be very distressful for patients, and this uncertainty is positively correlated with morbidity rates of depression and anxiety disorders. So this stress caused by the uncertainty is much more likely to be linked to mental illness, while hope, on the other hand, which we'll discuss this a little bit more later, hope is negatively correlated with all psychiatric symptoms in lupus patients. So stress specifically is something that is researched in psychoneuroimmunology of lupus because it is commonly believed to be associated with the experience of flare-ups and progression of the disease. Our first study we're going to look at was done and published in Germany, and it took urine samples from patients who experienced lupus, and it found that daily life stressors and major life events showed increased cortisol and neopterin levels in urine for up to 2.5 days following a stressful event. So these two hormones are not specifically associated with lupus, but they are indicative of the immune system involvement and of heightened inflammation. So obviously, lupus is a disease of the immune system, and it is characterized by chronic inflammation. So we can't necessarily say there's a cause and effect relationship here, but this may indicate that there is a level of reactivity um, in the immune system to stress, which could potentially cause lupus involvement. Another study found that daily life stress may be indicative of flare-ups of physical and psychological symptoms. There's no direct correlation between stress and flare-ups, but it did note that there was a much higher report of physical symptom experience in patients who experienced anxiety, depression, and anger. So when they were experiencing these distressed mental states, they were far more likely to report more frequent and more severe physical symptoms. Again, we're going to be looking at illness uncertainty. So illness uncertainty versus hope. With kind of the loom of the not knowing with the disease, that causes a lot of distress within the lupus patient, which indicated by the studies above, may cause progression of the disease, while hope, which these researchers polarized to illness uncertainty, I guess, hope was indicative of a negative correlation with all psychiatric symptoms and lower levels of stress experience. And then finally, lupus patients with insomnia report statistically significant higher perceived stress, which increases intensity of psychiatric symptoms and positively correlates with symptomatic kidney involvement. So the main takeaway from this one is that perception of stress influences the psychiatric symptoms that lupus patients are experiencing, and in response to that, it is shown that there is a higher correlation of essential organ damage and essential organ involvement in the disease. So all of these pieces of research kind of show us that there are some interactions between stress and psychiatric symptoms in lupus patients. They may not be linear, but there are interactions there that need to be minded as we're discussing treatment. So from the physical perspective, there is a lot of evidence supporting that early diagnosis and ongoing treatment are the best predictors of successful management. And obviously, when we're looking at a patient with lupus, it is most important that we take care of the immediate physical needs first. Mortality is of primal importance, but once we meet those basic needs, we need to consider the psychiatric symptoms. As we said, there are many reports of lupus patients feeling that they are not cared for psychologically. And this research that we've just paired with this has shown us that there is an interaction between mental health functioning and physical health. So with the unpredictability of the disease, there is no cookie cutter treatment. There's no one size fits all. Clinicians and physicians need to use targeted intervention. This is a tool that is used to, just like any other therapeutic technique, take a look at the client, where they are in their life and where they want to be, and how can we target their specific problem areas in order to help them reach their goals for healthy functioning. So once we have taken care of the basic physical needs and addressed all the symptoms, how can we cater to this patient's mental health functioning? In order to do that, clinicians can pull from a variety of tools, from therapeutic counseling, including support groups, education, supportive interpersonal relationships, faith and spirituality exploration, and simply just managing daily life stress and physical activity. Another important aspect of treatment is coping style. There is some research done on coping style and how it affects the progression of lupus. And these researchers found that avoidant and emotional coping styles were correlated with increased risk of depressive symptoms and distressed mental states. So as we said, psychiatric symptoms and distressed mental states are, if anything, but good for the progression of lupus. While the link may not be clear between psychological diseases and physical diseases, there is a difficulty in managing one when there is stress from the other. So, in order to combat this, clinicians and researchers um, decided that developing active and proactive coping styles not only prepares the patient for managing the acute symptoms and complications in that moment, but for the chronic symptoms as well, and prepares them for the future of the unpredictability and the uncertainty of the disease, but also just the stress of daily life. So, with all this information, there are some main talking points that we should just get through quickly. And the first one is that lupus patients indicate that their psychological symptoms and complications are overlooked, undertreated, and underappreciated. Um, Next, managing stress can mitigate the risk and severity of flare ups. While there is no cause and effect relationship between these two things, there are multiple interactions between um, emotional and mental functioning and stress and physical flare ups with lupus specifically. Emotional irritation, stress, and mental illness can interact with all autoimmune diseases to worsen the symptoms of each. And then, after the physical symptoms have been treated, treatment of psychological symptoms becomes important for managing the disease, but most important for promoting daily life satisfaction. So, as I believe I mentioned earlier, lupus is not a curable disease. Um, But it is able to be managed, like we said, by treating the immediate symptoms and managing the disease in order to avoid complications. So, by treating the psychological in the long term management of the disease, we are not only promoting daily life satisfaction, um, but we are managing the disease in a way that puts patients at a much lower risk for further complications to their physical health. Uh, Even if we weren't, managing physical health, why would we not want to promote life satisfaction? It's This is a stressful disease not only because it's unpredictable, but it is incurable, um, and so we can't change that, but we can make coping with and living with the disease easier just by managing the psychological symptoms and by providing patients with the tools to cope with the stress of their life themselves. Um, there are countless tools that we can give patients, and that as clinicians we can use. Like I said, not only therapeutic counseling and support groups, but exploration of faith and spirituality, stress management techniques, and education on the disease as well. All of these things are so important for managing um, not only the symptomology and the experience of the disease, but the satisfaction and the understanding of the disease itself and where that fits in the patient's life. Here are my sources, and thank you guys for listening. Hit me up with questions, I guess, since this isn't live. Thank you.